Yeah, good evening to all the participants in Europe. Good day, Mark, to you in Toronto. It's a pleasure to welcome you to today's ESTS webinar, where Professor Mark de Barrot will give us an update on surgery for malignant pleural mesothelioma. The topic has recently, with the presentation of the MAS2 trial results, gained new interest in the broader perception with controversial views of different trial participants on the UK side. So we're very much looking forward to hear the Canadian perspective. Mark de Barrot is head of the mesothelioma program at the University of Toronto, and I think everybody knows him in the field. So it's really a pleasure to have you here, Mark, and we're looking forward to your presentation. For the participants, as always, if you have any questions, please write them either in the chat or in the Q&A tool, and we'll discuss them after the presentation. Over to you, Mark.
Thank you very much, Clement. It's a great pleasure to be participating today. And thank you very much for the invitation on the kind introduction. So I'm going to share my screen. Okay, is that okay? Okay.
Yeah, perfect.
So thank you again for the introduction. So this is an update on surgery for pleural mesothelioma, and particularly on the role of surgery in the era of immunotherapy. I have a few conflicts which don't really affect the talks, but for everybody to be aware of. So the objectives today from my presentation will be to present on demonstrate the importance of molecular testing in mesothelioma, then define the importance of immunotherapy in mesothelioma, and then review the role of surgery in mesothelioma in that context. So as you're well aware, pleural mesothelioma is related to asbestos exposure. Increasingly, the exposure can be environmental rather than work-related, and there is still an increasing incidence worldwide, particularly due to the use of asbestos that is ongoing in developing countries. And this mesothelioma is associated with poor prognosis and no curative treatment at this stage. So if we look back at the survival after the diagnosis of mesothelioma, it typically had ranged between 6 and 12 months, with variation depending on prognostic factors, and particularly the performance status, the histology, on the presence of inflammatory markers that has been quite variable, from white blood cell count upregulation, platelets, CRP, and fibrinogen have been particularly described as poor prognostic markers. Now, the standard of care had changed about 20 years ago with the trial demonstrating the benefit of cisplatin pemetrexed over cisplatin alone, with a median benefit in terms of overall survival of 2.8 months or nearly 3 months. The main benefit of the chemotherapy was also the impact on quality of life and symptoms, with a response rate of about 41% with the dual cisplatin pemetrexed. Time to progression was 5.7 months. Now, over the past 10-15 years, one of the major changes in mesothelioma has been the understanding of the genomic alteration of the disease, with in particular the evidence of mutation in BAP1, CDKN2A or P16, and NF2 alterations, which predominates with different proportion in the subtype of mesothelioma. So the BAP1 loss is present in about 2/3 of the patient with epithelioid mesothelioma. CDKN2A or P16 homozygous deletion by FISH is present in about half of epithelioid mesothelioma and at least 2/3 of patients with non-epithelioid mesothelioma. And then the NF2 alteration, which is present mostly, although at a lower level, in sarcomatoid disease. Now, these alterations have been helpful in terms of diagnosis. So BAP1 loss on P16 homozygous deletion can separate benign from malignant disease, even though there may not be invasion on the histologic biopsy. So the presence of BAP1 loss or P16 homozygous deletion in the absence of invasive mesothelioma has now been determined to be mesothelioma in situ if there is no abnormality of the pleura or no abnormality on the CT scan. Now, these genomic alterations also have importance in terms of prognosis. And in that paper, we can see that BAP1 loss or P16 homozygous deletion negative, so ongoing expression of CDKN2A were independent predictor markers of survival independently of histology. The BAP1 loss has also been shown to be an independent predictor of survival and potential response to chemotherapy in that study involving a large Australian cohort with validation in the Danish cohort. We can see that the survival after chemotherapy in mesothelioma was significantly better in the group of patients with BAP1 loss compared to those with BAP1 retained, 19.6 months versus 11.1 months in the Australian cohort, on 20.1 months versus 7.3 months in the Danish cohort. So quite substantial difference. Now, the P16 homozygous deletion is also potentially an important confounding factor in surgical series. This is a study from the Memorial Sloan Kettering Cancer Centers in New York that is back from 2006. But you can see that the presence of P16 homozygous deletion negative, so non-deleted CDKN2A, you can see that the median survival was 34 months versus 10 months in P16 homozygous deletion positive. On the P16 homozygous deletion status was independent predictor of survival in the multivariate analysis. So quite strong significance in terms of predicting outcome. So in summary, the molecular markers, in particular BAP1 loss or P16 homozygous deletions, are abnormal in the majority of patients with mesothelioma and are increasingly helpful for diagnosis. They also define population of patients with better survival independently of the histologic subtypes. Response to chemotherapy may predominate in BAP1 loss tumor. On P16 homozygous deletion could be an important confounding factor in some of the surgical series, explaining the wide variability in terms of survival in some of these surgical series. But more importantly, BAP1 loss on P16 homozygous deletion could be important biomarkers for selection of patients for multimodality approach. Now, I'm just going to give you a little bit of an update on the immunotherapy, which clearly has changed the field of mesothelioma, and that came after the publication of this trial, the Checkmate 740 trial that was published 3 years ago, demonstrating the benefit of ipilimumab, nivolumab versus cisplatin pemetrexed, with a median survival increasing from 14.1 months in chemotherapy to 18.1 months in the ipi-nivo therapy. This was a large phase 3 trial involving 605 patients. And the hazard ratio was 0.74, so clearly beneficial for immunotherapy. Now, post-hoc analysis demonstrated that the benefit was particularly evident in the non-epithelioid mesothelioma rather than the epithelioid mesothelioma. This was a post-hoc analysis, so to take with some precautions in terms of significance, but the evidence is quite clear between epithelioid and non-epithelioid. Now, the other part that is important that can be seen in this trial, and that is important, is that the patients who respond to immunotherapy may be different than those who respond to chemotherapy. And you can see that in the early part of the survival curve, there is a group of patients who respond to chemotherapy and do not respond to immunotherapy. And the progression-free survival was quite similar between IO and chemotherapy at 6.8 months versus 7.2 months. But the main benefit of the immunotherapy were seen in those who responded with a durable response to immunotherapy that was ongoing beyond 2 years compared to chemotherapy, where the impact was fading out. The investigators also looked at potential biomarkers, and in particular on inflammatory gene signatures was shown to be potentially predictive. The response to immunotherapy with signatures combining CD8, STAT1, LAG3, and CD274, which is the gene for PD-L1. That signature was not predictive in chemotherapy, which supports his potential value in the IO predictability. Now, there has been another more recent trial demonstrating the value of immunotherapy. This was a trial that was performed in Canada, France, and Italy, comparing chemotherapy with or without pembrolizumab. Chemotherapy was standard of care platinum pemetrexed for 6 cycles. Pembrolizumab was given in the investigator arm with Q3 weeks for up to 2 years. This trial was presented last year at ASCO and recently published in Lancet. It was an open-label randomized trial 1-to-1 with 440 participants. And you can see that there was a significant benefit in the combination of chemotherapy with the addition of pembrolizumab, with a benefit at 2 and 3 years survival on a hazard ratio of 0.79. Now, similarly here to the CheckMate trial, the benefit was mostly seen in non-epithelioid mesothelioma or not in epithelioid mesothelioma. Again, this was a post-hoc analysis that was not planned, but clearly a benefit that seems to be more favorable in the non-epithelioid mesothelioma, similar to the CheckMate trial. So immunotherapy in mesothelioma, these 2 trials have clearly shown that mesothelioma is an immunogenic tumor that responds to ipi/nivo and chemo-pembro. However, there is a large group of patients who do not respond to first-line ipi/nivo, and the non-responders seems to be preferentially seen in the epithelioid mesothelioma. It also seems that patients who respond to immunotherapy may be different than those who respond to chemotherapy. And it raises the questions is how do we integrate immunotherapy to optimize the outcome of patients with epithelioid mesothelioma, which are often patients that we will favor surgery. So there's a bit of a dichotomization between the benefit of IO in epithelioid mesothelioma, and it still leaves the question open as to what is the role of surgery in these patients who may not be IO responsive. So now I'm going to present the role of surgery for mesothelioma, and I will go over some of the clinical trial on in particular the MARS-2 trial. But just to define the type of surgery that I will be discussing is mostly the macroscopic complete resection, so MCR surgery. Surgery in mesothelioma has a role for diagnosis with biopsy, which is still very important. Despite the biomarker, we like to have histologic confirmation of an invasive mesothelioma. There is also a potential role for surgery in pleural space complications related to mesothelioma. But what I will be discussing more specifically is really the role of pleurectomy decortication for early stage disease, stage 1 or in situ, extended pleurectomy decortication with resection of the diaphragm or pericardium for locally advanced disease, or extrapleural pneumonectomy also for more advanced disease. One of the key trial in surgery for mesothelioma has been the trial published by Valerie Rush over 20 years ago now, demonstrating the potential added value of high-dose hemithoracic radiation with extrapleural pneumonectomy. This was the first trial demonstrating that if you combine a hemithoracic radiation with surgery, you could improve local control. On most of the patients who were cured in this trial were outside of the radiation field. And you can see that the recurrence were mostly in the peritoneum or the contralateral pleural space or contralateral lung, with a few patients having distant recurrence. This trial has led to a number of three-modality therapy trials combining induction chemotherapy followed by extrapleural pneumonectomy on adjuvant hemithoracic radiation at high dose over 50 gray. And these trials have been somewhat disappointing in the sense that the median survival did not really change compared to other non-surgical trials, with median survival ranging between 16 and 20 months in this large prospective phase 2 trial. There was, however, a subgroup of patients who completed the three-modality therapy, and that included the adjuvant radiation component of the treatment. And you can see that the survival in these patients was better, but it could certainly have been a selection process for the fit patients being able to be having ongoing treatment. Now, the other part you can see is that 40 to 60% of the patients were not able to complete all three therapies. Now, a trial that was performed at the same time was the first randomized trial in the UK, and that randomized trial was defined to determine whether there was a role for extrapleural pneumonectomy in mesothelioma. So this was the timeline of the trial, so mostly histologic confirmation, adequate staging with PET on the mediastinoscopy. Patient underwent 3 cycles of chemotherapy, and then they were reassessed and randomized to surgery with EPP versus no surgery, and then they were monitored. So patients, 50 patients eventually were randomized after chemotherapy to surgery with possible adjuvant hemithoracic radiation versus no surgery. This trial was a feasibility trial to define the ability to enroll 50 patients in 1 year. It was negative from that perspective in the sense that it took 3 years to enroll the 50 patients. And one of the limitations of the trial was the important crossover on the perioperative mortality, which was 12.5% in the surgical arm. And 16 patients completed the EPP, but in the non-surgical arm, 3 patients still underwent EPP off trial, and 3 underwent pleurectomy decortication, so a lot of crossover. The trial demonstrated that EPP was potentially deleterious with a survival that was significantly worse after adjusting for a number of covariates such as sex, clinical stage, histology, and age. The median survival in the non-surgical arm was 19.5 months versus 14.4 months in the surgical arms. A number of limitations were raised with that trial, and in particular the small sample size, the crossover in the non-surgical arm, on the unexpectedly high perioperative mortality. Nevertheless, that trial on the results from the phase 2 three-modality therapy trial have led to a switch from EPP to EPD. We were increasingly becoming comfortable to do pleurectomy decortication with resection of the pericardium plus or minus the diaphragm. There was increasing use of EPP, which can be seen in a number of trials over the past 10-15 years due to the low mortality, faster recovery, but still some greater value in the less advanced disease. Now, the role of pleurectomy decortication or extended pleurectomy decortications in the face of the T category is well seen in that large study from the Brigham in Boston, where they reviewed 335 patients undergoing PD or EPD, macroscopic complete resection in 304 patients, mortality of 3% at 30 days on a median survival of 20.7 months, which is good, but the difference in survival is quite largely dependent of the T status, going from 43.8 months in T1, 25.7 months in T2, and then decreasing to 19.1 months in T3 and 11.6 months in T4. And you can see that the hazard ratio rapidly goes up as the T status increased, indirectly showing some of the limitation from PD in more advanced disease. So there's been a change in strategy following the three-modality therapy with increasing use of EPD, and that led to the MARS-2 trial, which was one of the randomized trials looking at chemotherapy on EPD. The other randomized trial was the ORCT 1205 trial that compared EPD with neoadjuvant chemotherapy versus EPD with adjuvant chemotherapy. Both of these trials were presented at the World Lung last year, and the MARS-2 trial will be published very soon. It has been accepted for publication, and I will look a little bit more at the MARS-2 trial. The other change that has occurred with the switch to EPD was the role of hemithoracic radiation. And the group in the memorial, in particular, have demonstrated the value on the feasibility of combining high-dose hemithoracic radiation in the adjuvant setting after EPD, and that has led to the IMPRINT trial, which I will also briefly mention, which is an ongoing phase 3 trial. And then, in our experience, the three-modality therapy led us to switch to a treatment of induction radiation, which, in our experience, was really the most favorable of the three components of the three-modality therapy. Combined with surgery, initially EPP in the SMART trial, and now pleurectomy decortication in the SMARTER trial. And I will present our ongoing trial that include that approach with IO. So this is the MARS-2 trial, which was a large randomized trial performed in the UK. Certainly a very important trial. And I will go over the design of the trial. If you look at the inclusion criteria, patients had to have a diagnosis of pleural mesothelioma that was confirmed histologically. Patients needed to have a surgically resectable tumor, which was not further defined, except that it had to be limited to one hemithorax, and performance status had to be 0 or 1. And accrued 335 patients. Patients underwent 2 cycles of chemotherapy with platinum pemetrexed, and then they were staged with a CT. If still resectable, they underwent pleurectomy decortication versus ongoing 4 cycles of chemotherapy, randomized 1-to-1. Patients who underwent pleurectomy decortications then went on to have the additional 4 cycles of chemotherapy in the adjuvant setting. Primary endpoint was overall survival, secondary endpoint PFS on quality of life, as well as safety. So the trial demonstrated that the surgical arm did significantly worse than the non-surgical arm. And you can see the overall survival curve here with surgical group that did less well, and eventually the two arms joined together at 3 to 4 years after the surgery. The progression-free survival, PFS, was very similar between the two arms. Now, if we looked a bit further into the histological subtype, you can see that a lot of the differences between the surgical and non-surgical arm came from the non-epithelioid arm, which clearly did worse in the surgical setting versus the non-epithelioid treated without surgery in red on that graph. And if you look at epithelioid treated surgically or non-surgically, the two arms were fairly close together and not significant, with an hazard ratio of 1.12 crossing the 1. So overall survival clearly was different based on histology and was worse in the non-epithelioid mesothelioma. So the conclusion from the MARS-2 trial, and we're going to wait to see the final publications to potentially dig down in more of the details. But currently, it does clearly demonstrate that not all patients with surgically resectable disease should have surgery, and we really need to be more specific in selecting our patients. Patients selected for surgery should obviously be carefully selected, and it does raise the or support the fact that non-epithelioid disease should likely preferentially be treated with ipilimumab and nivolumab. So if you look at the immunotherapy trial, clearly there is a dichotomization between epithelioid and non-epithelioid. On IO is certainly a preferential treatment as first line for non-epithelioid disease, if you took into account the MARS-2 trial as well. It does also potentially raise the question about extended pleurectomy decortication, whether it is a good surgical option for locally advanced disease, and raise the possibility that EPP may still be a well-suited option for, again, very selected patients. But most importantly, we really need to have better staging and look at biomarker for selecting our patients for surgery. That's really what it comes down to. Now, the other changes that have occurred over the past 10 to 20 years has been the advance in hemithoracic radiation. The initial trial from Valérie Ruch was using 3D conformal radiation, and that has switched to IMRT with extremely good results using a more specific target with less risk of contralateral long side effects with radiation-induced pneumonitis. And more recently, the benefit potentially of proton beam therapy as an even greater way to target the tumor while preserving the key organs such as the heart, contralateral lung, spine, liver, etc. So I'm going to briefly mention the IMPRINT trial, which is an important trial, but the trial has a difficulty to accrue because of the recent changes with immunotherapy on more recently even with the MARS-2 trial. But this was an interesting trial looking at the role of MRT after surgery in the adjuvant setting. The group from the Memorial demonstrated the value of pleural MRT after pleurectomy decortications with limited toxicity, 7% of grade 3 pneumonitis only, no grade 4 or 5 toxicity, but still a fairly high rate of local progression, supporting the potential benefit of combining surgery on adjuvant hemithoracic radiation, pleural-based IMRT. So this was the rationale to conduct that randomized trial where patients will be treated with pleurectomy decortication followed by chemotherapy and then randomized to radiation versus no radiation. More recently, the trial has been modified in order to integrate immunotherapy as well. So that trial opened 4 years ago and is still ongoing. And now I will briefly mention our experience in mesothelioma in Toronto. And our experience goes back to the three-modality therapy here. And what we had seen where we were treated our patients with pre-op chemotherapy followed by EPP and adjuvant hemithoracic radiation was that there was a group of patients who stood out. And these were the patients who received the hemithoracic radiation, particularly in the absence of N2 disease. This was really the group of patients that seemed to particularly benefit from surgery and radiation. The hemithoracic radiation was given in the adjuvant setting, and only about half of the patients could get the treatment, or a bit more than half. On the number of patients getting hemithoracic radiation increased as experience increased. But clearly giving it post-surgery was not optimal to design the field of radiation, but also to have the ability to give the treatment. So we decided to switch to the potentially most beneficial component of the treatment, and that was the radiation that we switched as an induction treatment, followed at the time by extrapleural pneumonectomy to limit the risk of pneumonitis. And then we left the possibility of adjuvant chemotherapy based on the intraoperative findings. So the goal of the trial on that switch was to deliver the radiation optimally to the tumor bed with potential boost based on the CT scan and PET scan findings. Another goal was to sterilize the edge of the surgery before proceeding with the surgery to limit the risk of seeding in the pericardium or the peritoneal cavity. The treatment design was also a lot shorter, 5 days of radiation versus 5 weeks. And as we progressively learned, that short course of radiation was immunogenic. So this was the first trial, the SMART trial. The treatment was 25 gray in 5 fractions delivered over 1 week, so 5 gray per day for 5 days or 5 open days. Patients underwent extrapleural pneumonectomy about a week after the end of the radiation to prevent the risk of pneumonitis. And then patients recovered. If they had N2 disease, they were eligible for adjuvant chemotherapy. So we did a first trial, which was a feasibility trial demonstrating the possibility and safety to give preoperative hemithoracic radiation with 1 patient who died within the 3 months postoperatively from an empyema. And we looked at our initial disease-free survival, and there was quite a significant difference between biphasic and epithelioid disease, with some encouraging results in the epithelioid group. We therefore extended the trial to a phase 2 trial that was still a single-arm trial. We didn't feel that there was enough support for randomization at the time. And we eventually did this phase 2 trial occurring about 100 patients on protocol. 96 patients were treated on study. We had a few additional patients who were treated off protocol for different reasons. They couldn't be included in the SMART trial itself. Large number of these patients who were treated off protocol had prior chemotherapy before being referred to us. Some of these patients also had locally more advanced disease with N2 disease or T4 disease, and also were not eligible because of that. All patients had preoperative IMRT, 25 gray in 5 fractions, followed by EPP. 30-day mortality was 1%, and 90-day mortality 3.1%, and we did not see any radiation pneumonitis. All these patients had on EPP by design of the trial. All these patients had the bronchial stump covered at the time of the surgery, with mostly the posterior pericardium on the left side. That's quite straightforward, but on the right side, we were able to typically use the posterior pericardium to cover the bronchial stump prevent the risk of BPF. Now, a lot of these patients were advanced disease. This is the final pathology of the explanted specimen. You can see that 10 patients, about 10% of the patients had T1 or T2 disease, but 90% had T3 or T4, and about 50 to 60% of the patients had nodal disease as well. The survival of patient on study or off study was very similar. If anything, a little bit longer off study. There was a few more epithelioid disease patients off study, but survival quite similar, ranging between 24-30 months, with the median, including both groups, of about 27-28 months. Now, what we've seen in the trial is that patients with early stage did not actually do as well postoperatively or within the first year, suggesting that EPP may be a better strategy for T3, T4 tumor. In the long term, the survival was quite similar. But if you take the T3, T4 tumor, the median survival was somewhere between 24 and 27 months. Now, the benefit of the treatment was mostly seen in epithelioid mesothelioma, and you can see here patients with N0 disease in the context of epithelioid mesothelioma had a median disease-free survival of about 4 years versus 1.5 years in the N-positive disease, so N1 or N2, based on the 7th TNM edition. And then the overall survival, also median survival of about 5.5 years in the N0 disease, compared to about 2 years in the N-positive patients. The last point on another important point that we notice is patients who have grade 4 complication after surgery never fully recover. So grade 5 complication, obviously mortality is important, but we've seen that the grade 4 complications still had an impact on long-term survival. If a patient had grade 4 complication, the median survival was 13 months versus 25 months in the absence of grade 4 complications. And that remains significant in the multivariate analysis. So overall, the predictor of survival were histology and N2 disease and grade 4 complications in terms of predictive marker. Now, I'll focus a little bit more on some of the correlative studies that we've done since that publication. On that work is not yet published, but we've looked at BAP1 on P16 homozygosylation as potential biomarkers. Initially, we thought BAP1 would be associated with better survival due to the prior results with chemotherapy. And we can see that BAP1 loss versus BAP1 retain really has had no difference in long-term outcome. What makes a big difference is the P16 homozygosylation. And patients with P16 homozygosylation negative, so CDKN2A remaining expressed, has much better survival than P16 homozygosylation positive tumor. And that remains significant in the multivariate analysis. And more specifically, if you look at histologic subtype, you can see that epithelioid tumor, P16 homozygosylation negative, had a median overall survival of 66 months, a median DFS of 61 months. The benefit was still seen to some degree in the biphasic, but a lot less on survival was not different. So in epithelioid disease, the P16 homozygosylation could potentially be a very good biomarker to select patients for preoperative radiation followed by surgery. What we've seen as well is the impact of, or potential impact of the immune response on the benefit of patients who had surgery after radiation was predominantly seen in patients who had a high CD8 tumor-infiltrating lymphocytes after the radiation, on a higher PD-L1 expression in the epithelioid component of the trial. On that, CD8 tumor-infiltrating lymphocyte remained an independent predictor of survival as well, with an hazard ratio of 0.47. So the radiation could be immunogenic potentially, and we validated in a number of mice model reproducing the treatment of a short course of radiation in mesothelioma here. So what have we learned from the SMART trial is that the short course of preoperative radiation is feasible and can be safe before extrapleural pneumonectomy, at least in our experience. It does require expertise in radiation and surgery, and particularly for the use of EPP. Grade 4 complications do impact overall survival, even though these patients recover eventually from the surgery. The recovery is never as complete as it would have been without grade 4 complications. So clearly something to avoid after surgery when selecting patients. EPP may be a better option for T3, T4 tumor, leaving the possibility that pleurectomy decortication is likely preferential in earlier stage disease with less physiological impact in a well-functioning lung. And there was excellent survival in epithelioid mesothelioma with P16 homozygous deletion negative tumor with an OS or median OS and median DFS reaching more than 5 years. And the short course of radiation could be immunogenic. So now I'll just present our ongoing work over the next or last few slides. Just to show a trial that we recently finished that we'll present at the AATS was to decrease the dose of radiation. So we've seen that giving 25 grain 5 fraction was feasible prior to extrapleural pneumonectomy. That trial was designed to decrease the number of fraction to 3 fraction with a dose escalation hemithoracic radiation prior to surgery that included predominantly extended pleurectomy decortication to demonstrate that there was a feasibility to give hemithoracic radiation before EPD. We used that trial to define the effect of the radiation on the immune response, both at a low dose radiation, so subablative radiation, but also at a high dose radiation, ablative radiation. Beside the hemithoracic radiation, the gross disease was boosted to an ablative dose, which allowed us to compare both. And we also used the blood and the plasma to look at the effect of the radiation. EPD was the main form of treatment in that trial, and most of these patients had extended pleurectomy decortication due to the volume of the disease. Overall, we've accrued 12 patients on the trial, a 3+3 trial, going from 0, 6, 12, and 18 gray of radiation to the hemithorax plus the boost. And then we had the second cohort that was treated off trial with the same approach as we gain experience with each of these radiation doses. Vast majority of the patients had epithelioid histology, but 3 patients had biphasic and final pathology. And then the surgery is done about 9 days after the end of the radiation, so between 1 and 2 weeks. As I mentioned, most of the patients had a pleurectomy decortication and a few had an EPP. I won't go into too much of the details, but just to show that even though EPP was an option, the patients who underwent treatment in the SMART protocol had lower bulk of disease, a lower volume of disease compared to our experience prior in SMART. Then just to show a few of the results that we had shown last year at the EMIG meeting, radiation was associated with an immunogenic response with upregulation of IL-15, FLT3 ligand at the time of surgery post-radiation, and then the spike decreased during follow-up, and then CXCL10, which is a chemokine that is associated with the upregulation of a Th1 response, started to be upregulated during follow-up, and as well interferon gamma was going up. Then we've had single cell analysis from a large number of tumors, which allowed us to tease out some of the effect from the radiation. with an activation of the cytotoxic T cell on upregulation of coenzyme B, and also a change in the macrophage infiltrating the tumor. So tumor-associated macrophage switch from a TREM2 phenotype to an IL-15 phenotype after the radiation. So this is what we've learned from SMART-Air, is that hemithoracic radiation up to 12 gray in 3 fraction can be given prior to extended thoracotomy decortication. Subablative radiation, based on data that I have not shown here, but was superior in terms of immunogenicity to ablative radiation. And then the benefit of that short course of radiation is to a large degree related to a shift in the macrophage phenotype population post-radiation. On these results provide the rationale to combine subablative radiation on surgery with immunotherapy, which is what we are currently doing in our ongoing trial. Patients who are surgically resectable, T1 to T3 and 0 and 1 untreated mesothelioma, have 3 fraction of radiation up to 36 gray in 3 fraction, followed by surgery, EPD or EPP. And then during the gap between the radiation and the surgery, they are randomized to low-dose cyclophosphamide in order to block the regulatory T cell. And then they can have immunotherapy in the adjuvant setting after surgery in the form of tremelimumab, durvalumab, so CTLA-4 inhibitor on PD-L1 blockade. So in conclusion, immunotherapy is a standard of care for non-surgical patients with preferential benefit in non-epithelioid mesothelioma. There is, however, a large group of patients with epithelioid mesothelioma who do not respond to first-line ipi/nivo, and that's important to keep in mind. And these are the potential patients who may particularly benefit from surgery. SMART with induction hemithoracic radiation, 25 gray in 5 fraction, followed by EPP, does achieve very encouraging results with median DFS on OS greater than 5 years in P16 homozygous deletion negative epithelioid mesothelioma. Hemithoracic radiation with 12 gray in 3 fraction can be used as an immunogenic radiation boost and can be safely associated with pleurectomy decortication with value in early stage disease, particularly epithelioid mesothelioma. On SMART-Air provide a safe and effective platform potentially for immunotherapy in surgically resectable patients with P16 homozygous deletion negative epithelioid, predominantly mesothelioma. And the benefit is due to a switch in the tumor-associated macrophage from TREM2 to IL-15 macrophage, so on M2 to an M1 switch predominantly here. So it's just a reminder of what we're doing all this work. And this is a patient who was treated by SMART about 8 years ago now, and he was back to help us to raise money for UHN 3 years after his treatment. And again, he's currently here about 8 years since his treatment without recurrence. So this is really the work that is associated with many people, on particularly John Shaw, that I'd like to highlight, who developed this radiation protocol. And then Penny Bradbury, who is also very involved in our program on the medical oncology side. And then our pathologist who implemented P16 homozygous deletion by FISH as a prospective component of the evaluation of the tumor preoperatively here. Thank you for your attention.
Yeah, thank you, Mark, for this excellent presentation and overview. I'd like to start with a very practical question. How do you currently stage your patients considered eligible for surgery initially? How do you do the restaging? And maybe you can elucidate a little bit what were the considerations of placing the immunotherapy in the adjuvant setting in the SMART-Air protocol?
Yeah, thank you, Clemence. Great question. Sorry for the phone. So the staging that we use is so CT, chest, on abdomen. We use a PET scan as well for all our patients. Majority of the patients will also have mediastinal staging. These are really the main staging parameters that we use. Now, what we're starting to use more frequently is the P16 homozygous deletion by FISH as a biomarker. So that increasingly is affecting our decision. And we'll probably have more definitive answer with our last trial where we did not have that as a biomarker. But it does seem to support what we were finding retrospectively in the other two trials. So the staging is really CT, PET, mediastinal staging, and then increasingly biomarker as a tool to help us make the decision, in addition to the clinical evaluation of the patient.
And the immunotherapy in the adjuvant setting?
Yeah, so the immunotherapy, so initially we decided to use it in the adjuvant setting because of the potential toxicity with the radiation and the potential toxicity in the induction setting, before surgery, and that's particularly related to CTLA-4 inhibitor that has still a fairly high rate of grade 3 complications. So we decided to put it in the adjuvant setting to keep the short window between the radiation and the surgery, to make sure that radiation could be safely delivered and to make sure that patients were not dropping out of potential surgery due to side effects from the immunotherapy. It is certainly debatable on the discussion that we have right now is whether we should switch some of the immunotherapy in the neoadjuvant setting, with or without radiation. So that's certainly one consideration. The other consideration is the type of immunotherapy. So increasingly, we see that the immunotherapy with ipilimumab, nivolumab may not necessarily be the most appropriate type of immunotherapy for epithelioid disease at an early stage. And from our single cell data, there's a large number of patients with epithelioid disease where we don't see evidence of CD8 T cell exhaustion, suggesting that potentially these are the tumors that may not respond to immunotherapy. So there may be other type of immunotherapy that may actually be more beneficial in this early stage mesothelioma. So these are the discussions we have currently, but the decision to put it in the adjuvant setting was mostly from a safety perspective and in relation to the radiation, and also from a feasibility to make sure that patients will proceed with surgery after the radiation without risk of toxicity from the IO in the neoadjuvant setting.
So there are a lot of questions. So David Wallace asking whether you prefer EPP or EPD, what do you consider superior? And Alberto Cabanero is asking in the same direction, if you have a planned pleurectomy decortication with more disease than expected, would you finish the procedure leaving macroscopic tumor behind or rather switch to an EPP?
Yeah, no, these are great and important questions. So we've done a lot of pleurectomy decortication, particularly with the smarter, experience. And currently, we've went back to doing more extrapleural tonectomy. So if the lung is not involved or minimally involved by the tumor, we will preserve the lung. If the lung is quite diffusely involved by the tumor, we will rather do an extrapleural tonectomy. We can get a sense of that often on the preparative CT, where we can see some degree of infiltration in the lung. And generally, if that's the case, then we will plan more particularly on EPP and make a final decision in the operating room. But that also means that patients with more infiltrating disease on the preparative staging, if they are not eligible for EPP, we will not include them for surgery. So trying to avoid, facing patients where you plan on EPD and you will leave, an HER2 tumor behind. It has happened on it's not 100% definitive. There's still a potential benefit of the radiation with immunotherapy independently of the surgery. But in general, we've done currently looking at our current experience, it's about half and half. So about 50% will have colorectal decortication and 50% on EPP, depending to a large degree of the tumor volume and the infiltration of the lung.
And Eric Lim is asking, in view of the randomized controlled trials, whether we should be offering surgery at all.
Yeah, so it's debatable. I think offering surgery is still an important component to investigate. Certainly agree that surgery is not standard of care, so surgery should be done as part of a clinical trial. But I think it will be detriment to the patients not to investigate surgery further. And surgery, I think, has a role potentially in a very specific group of patients. If we take all the patients we see in our clinic, we do operate on about a quarter of the patients. So surgery is not what we favor the most. But there are a group of patients who seem to benefit from surgery. And increasingly, when we looked at our experience with preoperative radiation and surgery, it seems that patients who benefit from that approach are the patients who do not benefit from immunotherapy. So it seems that patients who do not respond to immunotherapy may actually potentially respond to subablative radiation. In our experience, that's been in the context of surgery as well. So I think there are a group of patients who still can benefit from surgery, but this needs to be well defined. And ideally, we should look at defining biomarker to select these patients. And that goes in the same sense of immunotherapy. So if you take the data from immunotherapy, the tendency now is to give immunotherapy to all patients as first line, but yet patients with hepatocellular disease is still a very large number of patients who are not going to respond to immunotherapy with toxicity of immunotherapy that are still quite significant. 20% of them will stop their immunotherapy. Mortality from immunotherapy is still somewhere between 1% and 3%. So I really think that we need to have biomarker to select patients for immunotherapy, but at the same time, patients who are not potentially going to be immunotherapy responder may benefit from a protocol with surgery, on radiation surgery or other form of treatment with surgery. So that's kind of the way we're looking at it from our perspective.
Do you think it's feasible or meaningful in Canada to perform a trial where the surgical arm is where the surgery itself is randomized?
I think if we have the data to demonstrate the potential benefit or lack of benefit, I think it will be feasible, but I don't think Canada will be sufficient. I think we will look at multi-center trial beyond just Canada. Randomizing patients to surgery has been difficult, and I certainly applaud the group in the UK for finishing the MARS-2 trial. From the first MARS trial, we can see that there is difficulty to randomize these patients to surgery. So surgery may be more difficult to demonstrate. If we were going to do a randomization, we may randomize the radiation on it. Currently we don't do surgery without radiation. So that may be one way to define, indirectly the benefit of the combination is to potentially randomize the radiation arm rather than surgery. But I think a randomized trial will eventually be necessary. I do think that we need to be careful before designing such a trial to make sure that there is a potential value to do it on very strong evidence that there may be benefit but if we achieve a treatment that shows encouraging results, eventually randomized trial will be necessary. But it will be likely a multi-center trial beyond just Canada. Yeah.
There is no real evidence available, but what's your personal view on if you're performing surgery on adding any intrapleural therapies or any additions to the surgical procedure itself?
I think that's certainly a very valuable option. On intrapleural chemotherapy has been shown to be feasible. It does carry some potential morbidity, but certainly feasible. Intraoperative photodynamic therapy is also shown to be quite encouraging. So some form of intrapleural therapy is certainly encouraging. And the other possibility is intrapleural immunotherapy, which is another option that has shown to potentially be optimal in terms of delivery immunotherapy adjunct or with some form of cellular therapy. So there is certainly some potential benefit of intraoperative therapy. I do agree.
Okay, yeah, there are several questions more, but unfortunately, time's up for today. So, Mark, I'd like to really thank you very much for this excellent presentation, and to you as well as the audience for a really interesting discussion. There's a lot of questions still open, and looking forward to future studies also to come up. And today at the end, I'd also like to point your attention to the next ESTS webinar, which will take place on May 13th and deal with rare pathologies in pediatric thoracic surgery. And in between, also on the 22nd of April, we're going to have a BMS-sponsored webinar on case-based video presentations of surgery after neoadjuvant immunotherapy, and I'd like to encourage your participation in that. Thanks very much, Mark.
Thank you very much, Clemens, and thank you for the great discussion and for the great questions.
Thank you. Bye-bye.
Have a good day. Bye-bye.